Now, it's my great pleasure to welcome the first speaker in the next session, Andrew Connolly. Andrew is a general surgeon at Middlemore, colorectal surgeon, just finished as chair of the Medical Council of New Zealand and has recently been appointed to the Health Quality and Safety Commission. He has lots of other things on his CV, but he said all I had to say about him was his name, but I think I needed a few more sentences. Thank you, Andrew.
Thank you, and thank you for the organisers for the opportunity to speak today. And I'd also just like to acknowledge the wonderful welcome and thoughts that Ken highlighted this morning as a New Zealander. It's greatly appreciated. Look, I am, for the New Zealanders in the room, I have to reiterate, these are personal views. It should not be taken as where the Medical Council's thinking about this, but obviously it's informed by that. As a surgeon, I am occasionally wrong, but never in doubt, so this will be strong on opinion, and as my current and previous council CEOs know, fact may not be allowed to get in the way of that opinion. I'm going to focus mainly on those non-diagnostic issues because, frankly, AI and diagnosis is easy. It either works or it doesn't. You can audit it right or wrong, so don't sweat the diagnostic stuff. But there's no doubt that AI is developing rapidly. I am now in the same position of having to put the glasses on, actually. That is one mighty small screen. It does offer enormous potential, but I think it's very clear that certainly as a regulator, and I suspect if the Minister of Health was here or the Minister of Technology was here, they would agree too, at government levels, at hospital and service levels, we are way behind. And boy, if we think we're behind, imagine how a patient may feel if they took the time to look at this. We've already heard about the ethical framework, and there's a lot of work going on in the room now. I know the Australian Medical Council under Philip Pagoo's leadership is looking at the ethics, obviously many other areas. There are advances around the world. The Americans have the Care in the 21st Century Act and such like. So a lot of work is being done. Safety is not guaranteed in any of this because we don't know how big it's going to be. And of course, it's not a panacea. I think it's important to know that the basics aren't even really in place. We have 20 DHBs, which generally means 31 opinions. We have 20 DHBs and, all joking aside, countless operating systems. And they are so antiquated, they cannot work together. We don't know how data is going to be handled. We don't really know how we're going to address the logistics, let alone the ethical issues. What is it? What isn't it? It is artificial, but I would challenge whether it's actually intelligent, because I think it comes down to what we define intelligence as. It's clearly powerful use of information. And as a coalface clinician, what I need is much better information for my patient so that my patient can make an informed choice about their future. And it offers, of course, that ability to acquire massive quantities of data, and hopefully in a way that makes it easy to get the right answer in the right circumstances, rather than having to rely on how clinical coding may have put something in from 2010. It obviously has the ability to predict, and that is useful to me as a clinician to again go down that informed choice, informed consent route. Suggest various diagnoses, tell me if things that look like dogs, bark like dogs, walk like dogs are dogs. Also has the ability to deliver treatments. Now, we're told the avatars have empathy, but really? Are they empathetic? Can a computer be compassionate? Cultural appropriateness, cultural competence in certainly Australia and New Zealand, as in other jurisdictions with Indigenous populations, is crucially important. How do we train for it? And I think fundamentally, with any technology, and we've already heard this, is it just a fancy way of getting the same outcome, but it comes in a box, or does it actually make me a better clinician? Is it better than me? Am I better with it? Are the key sort of questions we need to look at. And I think this starts to come, when we get onto some of the regulatory side, makes it a bit simpler for regulators in the room to work out what to do with this. Now, the role will vary. We've talked about pattern recognition. And tragedy to, do away with radiologists and dermatologists. That'll just break my heart. Ophthalmology, cardio. We know it's good at the diagnosis, and it's not going to do away with those people. My apologies to the Radiology College. It won't do away with them. It will change their role. It will probably make their job more satisfying if it's done right. Are we at a position, though, to trust our destiny to a computer? And I would not like an end-of-life decision made in binary code. It should have this role in moving from informed consent, which is making me feel good that I can defend my position legally, to informed choice, which is the right answer to the right question in the right circumstances from the patient. And it can deliver treatments now. We know about robotics, and it's, of course, possible to code the computer to do the operation. There is no evidence a surgeon using a robot has any better outcomes than a surgeon holding a scalpel. But who knows? You could imagine massive advances, say, in the critically ill, where real-time physiology and infusions are being changed moment to moment by powerful computing science. And that may well be a good thing. Obviously, we've seen enormous advances in the computer abilities to localise the cellular at a very small level where radiation and so forth has to be delivered. So a partnership in these in the future looks good. So as the 21st century goes forward, many people have said before that doctors won't be replaced, but those who don't embrace technology will soon find they're falling way behind. I think the danger here, and this was touched on in earlier talks, is that some people do see IT as a solution to everything. And funders will see it. Now, I've made the point that machines don't need employment contracts, which is quite appealing in this country at the moment because we have some industrial strife in our resident medical workforce. But we do have to be careful on a more serious note that administrators do not see a computer as a solution to everything. And we have too many examples of where they have done that. Regulation is going to be critically important, and obviously jurisdictions in various ilk from parliaments through to individual colleges are going to have to grapple with this. But it does offer us also empowerment, I think, to explore alternative workforces, because the science and the accuracy, if you like, behind some of the computer systems we can utilise will make other roles safer, roles that currently require the doctor. We're entering an age of data-driven care. The previous Director General of Health said we were in an age of measurement, but I think we really are going forward with data quite spectacularly, and you'll see the term recertification. That's the term we use in New Zealand. It's essentially revalidation for the rest of the world. It's just simply our Parliament uses recertification. So the term should be seen as interchangeable, but the Medical Council has made enormous progress with our colleagues in the colleges on specialist revalidation, recertification, and a lot of it has an emphasis on doctors knowing the outcomes of their treatments in their patients. And out of that, of course, means that patients will know more about what they can expect. We can exclude likely diagnoses, but let's be careful we don't under-investigate or over-investigate. Again, that human context, it's great to order a CT, but what the hell am I going to do about it if it finds something? You need to understand the comorbidities, the circumstances, the desires of that patient about their life. Many of these problems of under or over investigation can be ameliorated if we start to see AI as part of the multidisciplinary team. So it's not to the exclusion of the rest of the team, it's an adjunct to the team. Some of you in the room probably have a brain that can actually understand the algorithms. I certainly don't. My knowledge of a computer is it has an on button. But really, we are going to have to, as we heard from the Radiology College, have some expert clinicians who actually understand the science behind all of this to make sure it's actually answering the questions our patients need. And it should improve outcomes. If not, why use it? Some of the systems issues or systemic issues we need to address. Trust has been raised prominently earlier in the day. We need to consider patients, regulators, clinicians. This list isn't exhaustive, but it's certainly complex even with those 6 bullet points. Let's turn to trust. The public have high levels of trust in their doctors. They don't have as much trust in their computers. And we can probably think of a few reasons why people in the United States may be more distrusting of computers under the current political environment than before. But trust is falling. And interestingly, trust in the safety of the internet has fallen most amongst those aged over 65, which really are the group in many respects that bring the most complexity to medicine, along obviously with the very young. And we need to, I think, consider very carefully what do patients want from their clinician if we're thinking of AI as being a form of a clinician. And Price Waterhouse, their health research group, have come up with those 11 factors that were very common. But interestingly, and it ties in again with earlier talks we've had, there's also a significant majority of those surveyed do want to use technology to help access healthcare. So it's finding that balance and that tension that's important. Issues for the public. This is Med School 101. Patients want to be involved in their decision making. They don't want doctors dictating their outcomes. They want to be partners in decision making. So there is this massive opportunity for relevant questions to be answered. And I think one of the greatest frustrations as a clinician when it comes to IT, at the moment I'm told, here it is, knock yourselves out, rather than me saying to the coders, this is what I need, knock yourself out. So I think it really does behove the leaders of medicine in all ilk to be front and centre on what we need the system to deliver. And if it is real progress for patients, it must be the stuff that the patients value as important, such as what is the risk in my hospital 20 k's south of here of losing my independence if I'm 75 with diabetes, dodgy kidneys, live alone, having my bowel cancer removed. I cannot answer that question at the moment, and that's a disgrace. I should be able to answer that by talking to my smartphone. Relevance has to be, therefore, to the unique clinical settings, the individual patient within that health system, not what the Mayo Clinic define as the outcome for South Auckland, nor should South Auckland define the outcome for the Mayo Clinic. Language barriers. At Middlemore, we have interpreters for 210 languages and dialects available. 210. So what happens if I ring up and get one of those ruddy automated things that tells me to push a few buttons and say a few words if I don't speak the language that is being run? Issues for regulators. I am going to come on to a few suggested solutions rather than just have a list of moans. But we do have to grapple with how this is governed and how it's maintained. It's really crucial, I think, how is it being regulated? And regulation, perhaps in this country as a therapeutic device, has been suggested. Certainly my successor, Dr. Curtis Walker, I'd like to acknowledge, has already made this a key strategic objective of the Medical Council to answer these sort of questions. Who approves the chosen system? And are we going to have this so-called autonomy of the 20 district health boards in this country all trying to decide individually what they want? Recertification, revalidation in the age of AI, I'll come on to. How do you upgrade it? If it's sitting in a server in California, what say we get into a trade war with the United States? Are we going to be stuck at AI 1.0 or are we going to get 2.0? These issues are not scaremongering, in my opinion. They're actually real. And, of course, that question, does it reflect our local needs as a nation? And does it worsen inequity? You can imagine just that language barrier on the helpline. Issues for clinicians. Integration into our practice. We're all worried about autonomy, but there's a great advantage here that with really good IT, more real-time data that we find useful in our practice, we should see reduction in unjustified clinical variation. We should see greater accountability. We should see better patient outcomes. But This is going to require fairly constant auditing. Now, we should be in a practice that engages and encourages audit as it is, but what happens when something does go wrong? How do we escalate the concerns? How do you institute a recall if the airbags on your AI machine aren't working properly? All need to be answered. Things around the updating and relevance to practice I've already covered. Do we risk devaluing humanity? Well, potentially. This country has recently learned the evils of the internet. There is no computer system that is attached to the internet that is free of risk. What is to stop a nasty little Russian in his basement in Moscow from trying to hack in to bugger up the health system in a particular country and send out a ransomware note? These issues do need to be considered if we go completely down the computer is great route or God route. You can probably tell I'm a bit of a technophobe. Now, the headline, the computer told the patient they were dying, is of course wrong, but that was the headline across the world about 10 days ago. It was a doctor telling the patient they had metastatic cancer. I think it was in Florida. I think it was certainly in the United States. But of course, it was on a robot that had driven the screen in, and the doc just happened to discuss that you got metastatic cancer. I don't actually think that's great medicine. But the public certainly reacted that it's very bad medicine. Outcomes, of course, in medicine rarely guaranteed. Acute and elective long-term conditions when they come in with an acute exacerbation versus a whole new, the nuances here start to get really difficult. So I think it goes back to that idea that if we can harness the technology to give us better information, we can do better for each individual patient. Is it beyond the realms of possibility that a government will be elected on a platform of no abortion, no contraception? Therefore, coders, you will not allow any of those suggestions to be in our AI pathway for women's health. That is not outside the realms of possibility. Workforce issues. It should actually help because it probably allows us to increase the scope of practice for those who haven't been through med school. It definitely should dramatically improve clinical pathway decision making in defined areas, and we obviously know the power of it in diagnostics. Releasing the radiologist to focus on the complex case rather than having to look at endless, fracture clinic x-rays is just a very easy solution. But there are questions how training will be accredited. Will accreditation of training need to vary depending on whether you're using IBM or Google or Huawei, which you may or may not be allowed to use in some jurisdictions? We've already heard of the issues of how on earth do we get students and undergrads involved in this. I don't think that's difficult if we make it part of the multidisciplinary team. So if we just see the powerful computers as part of our normal decision making, just like a CT scan is now part of our normal decision making, whereas when I was a first year house surgeon, it had to be a consultant discussion in Auckland Hospital, and you can only get one during business hours Monday to Friday because the technology was so new. So this will just become normal part of practice, and I don't think that's a tough one to get around. And so it's very easy, I think, to see solutions to the AI developments if we're seeing this as an adjunct to our clinical practice and as a partnership with clinicians rather than necessarily substitution. So let's turn on to possible solutions. Training. Touched on this now. Eminently suited to in-training assessment because if you think of it, it's just like getting a blood test or just like getting a CT. What does, whatever I call my computer system, what does Watson tell me about, say, the likelihood that chemotherapy is going to be of considerable benefit to this patient with this type of cancer? That's fine. That's very straightforward. So I think if we, again, just keep seeing it as a tool, how we train, how we assess, just fits in with many of the things we do now. Accreditation standards, I think there is a danger, particularly when you think about health inequities, of technology now separating patients, so the haves and have-nots in terms of their bandwidth start to become more problematic. And so will those organisations that accredit universities, accredit training institutions or facilities have to actually now consider what is the access and exposure to AI, are the facilities adequate, what is the audit and accountability, particularly if you're using it in the diagnostic type realm. Therapeutic use, probably the simplest way to approach this at the moment is around, as we do with any new technology. So when laparoscopic surgery came in, those surgeons who were well established in their practice had to go through a credentialing process. For those of us who trained in the laparoscopic era, it became just a normal part of training. So I think specific credentialing should be safe for sort of the technology side of applying, say, treatments. Using the robot would be a good example. Accountability is something that worries regulators a lot, but again, if we just see this as AI as part of the multidisciplinary team, the role of the doctor and the accountability of the doctor is very straightforward. This is very similar to the accountability I hold if my registrar rings me up at 2 in the morning and I say, that's great, you can do that, see you at 8. Was my delegation adequate? Was my supervision appropriate? So for AI, was it reasonable to utilise the computer for part of my decision making? And did I use that information clinically, professionally, appropriately? So it's not, I don't think it's a massive shift for a regulator to see AI as another tool. Did the doctor appropriately use the tool? The internet knows few bounds, and this is a real challenge again for all of us who have been involved in regulation, because you can do an operation with a robot sitting on the other side of the world. It's just you just need a connection, internet connection. So we're probably going to need regulation at various aspects and accountability. And I think I've got that little mantra there, clinicians and patients being informed but not governed. So because then you're able to establish rules around what the clinicians can do. Prescribing, there's nothing to stop a doctor in the States prescribing for a patient in New Zealand. They can write a prescription, but we have easy, established and enforceable processes to stop the pills being dispensed. So even though the computer might spit out a prescription, say in an online health system, governments have ways of making sure that is safe around the ability to import, distribute, dispense medication. So that's fine. Operations, you cannot stop someone with an internet connection running that robot if the connection's established. So we probably need to look at regulation of the facilities that have robots to establish the ground rules on who can do what. And this is the same as each jurisdiction establishing ground rules on who can report their CTs. It may be fine that the doctors overseas, how do we make sure that they're safe? So there's audit, feedback and so forth. The IT itself, licensing regulations, contractual processes, and obviously each jurisdiction can put in place, Parliament could pass a law tomorrow saying that if you're using X, you must be auditing in this framework, whatever. So I don't think the internet itself is a danger, as long as regulators and legislators understand that just saying you need to be registered with the Medical Council or you need to be registered with the Pharmacy Council or something isn't going to cut it unless there's some teeth to actually make that enforceable. Fully automated processes, doctors don't need to worry about this because obviously we're not held responsible. So once we've passed the buck, we're pretty happy. But should be safe for what fully automated processes are doing now, which is the pattern recognition stuff. We've seen in the earlier presentations, the accuracy, the sensitivity, specificity of these techniques, and apologies to the statisticians in the room, show that they're very good. And so they can just be continuously audited, that's fine. Accountability and responsibility in a fully automated system, though, is going to have to probably sit with the companies that develop this and the organisations that buy them. And so in New Zealand, we do know that with our health and safety legislation, in fact, I don't think it would be outside the realms of legal possibility to say that the CEO of the hospital could be held responsible if a fully automated system caused considerable harm. That, I think I'm getting nods from our legal experts, thank you. However, the internet, of course, a lot of it's sitting in the cloud, it's sitting in other countries, so there's probably going to have to be some international agreements around this. What do you do if people need to be held accountable or organisations held accountable? And robust processes around, obviously, the introduction is essential. And I've taken that old legal adage that a lawyer represents himself, has a fool for a client and a fool for a lawyer. As a surgeon, I would never allow a computer to do an operation on me. I'd rather stare into the whites of the eyes than stare into a blank screen of the surgeon. Legislation, that whole issue of transnational healthcare is fraught with risk. Obviously, we have no ability to act outside our territorial boundaries. For doctors, maybe contracts for doctors based overseas. So the provider of the service locally has a legal contract about what steps that doctor based overseas needs to do to satisfy the local laws and regulations. For the machines, I suspect it's going to be around standards, ownership of information. Do Google now own my health record? This really needs answering. Do I have the right to say I'm happy for my blood pressure to be in there but not my psych medications? We really need to have a conversation with the public about what all this means, because I think they are sorely lacking in the debate at the moment. So in summary, final slide, it's here, it's not going away. I think if we take the non-diagnostic aspect, non-therapeutic, if we look at the wider advantages, it opens tremendous opportunity, particularly to get relevant answers to the questions that patients need to make a choice about their health care. What is relevant to a patient in my clinic will not necessarily be the same to a patient even 10 k's up the road. We need to front foot a lot of these issues. We certainly need to keep the patients at the forefront of the debate. I think if we see AI outside of the diagnostic stuff, which is well established, if we see the next step as essentially making it part of our multidisciplinary approach to patient care, training and education and accountability all starts to fit together. So thank you for the opportunity to talk. As I said at the start, strong on opinion, weak on fact, but I hope it's given you some stuff to think about, particularly the regulators, administrators and educators in the room. Thanks.